This week on the BackTable podcast.
I have always used light sedation for all my prostate biopsies. I know that's a super controversial area because most urologists don't. They do them in the office, in the local, and that's fine. But when I was in residency, we had one attending who did them under light sedation and the others awake. And I really liked sedation. I thought if I ever do a biopsy on a family member or I need to have it done myself, I want to have it done that way. Because although the patients say that they tolerate it, their PTSD is real. When you have to re-biopsy them, they resist. So that's where the truth comes out. And I think the golden rule is you should do for all patients what you would do for your family.
The Jose Silva is your host this week. Today, we have a very special guest. He was my attending back when I was in residency in Puerto Rico, Dr. Ricardo Sánchez-Ortiz. He did his residency, his urology training at the University of Pennsylvania under Dr. Alan Wayne. After this, he went on to do a fellowship in uro-oncology at MD Anderson. Then he went back to Puerto Rico and established himself as the first robotic surgeon and first robotic program in urology in Puerto Rico. So, Ricard, I'm glad having you here. So, welcome to BackTable.
Oh, great, Oche. Well, I should say that you were one of our star residents. So we're sorry that you went back to Florida, but hey, it's their gain over there.
No, thanks for those kind words. You were always very good to me and very supportive. So let's get to it. So today we're gonna be talking about transperineal, prostate biopsy, elevated PSA, everything that has to do with that part of prostate evaluation, prostate cancer. So Ricard, can you go over what you did in residency, fellowship, and what are you doing now?
Yeah, sure. And thank you for the invitation. Certainly, this question has always been a nuanced question, but particularly the last 2 weeks with all the news, we have been getting a lot of questions from patients and from the media. So things have changed, obviously. I know I trained in the 90s and early 2000s, and we're sort of the generation that had rotary phones, and now we have iPhones. And we also had prostate needle biopsies without anesthesia, right? And so when I started my residency in 97, most people were just doing prostate biopsy transrectally, maybe with a little bit of lidocaine in the rectum, and towards the end of the residency, the program started using local blocks for the biopsies. Image guidance really did not exist except for ultrasound, obviously. We did do some at Penn. We did do transperineal biopsies, but they were with the old Vin Silverman needle, and basically Alan Wayne used to do them on patients who had an abnormal rectal exam. So he would do a 12-core. Usually, if the patient didn't have a prior biopsy, they would just do peripheral zone 10 or 12 core, and if they had a prior negative biopsy, they would do transition zone right or left. And then he would do a digital guided transperineal biopsy with the Vin Silverman needle. And he was amazingly accurate in getting the nodules. I remember we looked at that data, and he was very good at hitting it. Obviously, that it was a pretty large needle, and it was on the local, but the amount of tissue that you could get, sort of retrospect, gives you an idea of the fact that when you're doing transperineal, you're going lengthwise on the peripheral zone as opposed to going perpendicular. So I think that is definitely one of the advantages. When I got to Houston, at Anderson, they were all done with a local block, transrectally as well, and image guidance really did not exist. So that's how I started to do them when I got to Puerto Rico in 2004. Just straight up transrectal, fleet enema. And at Anderson, they used to add neomycin powder to the enema and just shake it up and then give a dose of Levaquin. That was it. So that was what I was doing when I got here in 2004.
So during residency, we had, I remember we had two changes. One thing, you mentioned the antibiotics. So I remember that there was no IOUA guidelines at that time. But before, we were doing 3-5 days. Then we switched to just 1 day, and then so. I mean, I'm still doing. I went back to 3 days, 2 days before, and the day of the procedure. Has your decision making in terms of antibiotics have changed, deciding between each modality?
Yeah, that's certainly something that has changed. I think initially I would do a quinolone the day before and 3 days after with a neomycin enema, and I would get occasionally I would get someone get a fever. So maybe 15 years ago, I started doing rectal swabs for Cipro-resistant species. And I think that was a game changer. At the time, we did a study with looking at the prevalence of quinolone resistance in our community here in Puerto Rico, and it was 17%. So not only was I seeing occasional patients of my own, but I was seeing a lot of patients in consult for prostatectomy who had been admitted. And I realized that really 17% quinolone resistance in the community is way too high for us not to do rectal swabs. So, I mean, if you look at some of the recent studies, like Badarmian did a great study in Albany comparing transperineal to transrectal without doing rectal swabs, and I was surprised that they didn't have any infections. And it's probably just speculating a function of the prevalence of quinolone resistance in the community. Because if I were to do a study, just I think they used a quinolone and a sulfa in that study. If I were to do that study here, I would definitely get infections because our rate was so high. So what I started to do when I was doing transrectal with the Cipro, the swab, I started to, instead of adding more antibiotics, I would put the patients on yogurt and probiotics for 2 weeks, and then repeat the rectal swab, and you'd be amazed on the number of patients that actually went back to sort of like a more wild type flora, which is weird because you're not really giving coliforms, right, when you give probiotics. But maybe it's just that if you check a rectal swab twice, you can get 2 different results. But so I started doing that for the occasional patient who would have a positive swab culture to resistant to Cipro, and then I would sometimes I would, if it wasn't multi-resistant, I would just switch to Augmentin and maybe add garamycin. So I would tell you that I did not have any sepsis cases since I started doing rectal swabs.
No, and I remember I was in residency when you started that trend in Puerto Rico, and talking about the importance of doing the rectal swab and talking about community resistance. Some places we had access to it, some other we didn't. But definitely those were things that, like you mentioned, a game changer at that time.
If you ask me, did I change to transperineal because of the infections? And the answer is no, because I wasn't getting any infections. I changed because all this data started to come out on the microbiome that I thought was super interesting. The microbiome affecting glucose control, metabolism, even cognitive changes in the future, cancer risk, and just loading up patients with antibiotics and just keep adding another antibiotic. Just if there was an alternative to doing that, then I wanted to explore it. I would say my eureka moment was at the AUA. I was having dinner with Manish Vera, who were residents together. He's at Northwell in Long Island, and Alex Skudikov, who's at Fox Chase. And we were talking, and Manish was saying, listen, we're going to go full 100% transperineal at Northwell this year. This is probably like 6 years ago, 5-6 years ago. And I was like, wow. At that point, I hadn't even done one transperineal biopsy. So Alex Skudikov said, listen, at Fox Chase, we're doing maybe half and half, but we're moving more towards transperineal. So I'm like, listen, there has to be something here. The folks at Music, I spoke with Arvin George, and Manish put me in contact with him, and he sort of shared their technique, and they had great videos at the time. This is 5 years ago, of how to do the transperineal, how to approach it. And then the AUA course was fantastic. I took it in Chicago, and it was Peter Pinto, Arvin George, a great group. So that's really when I started. I think it must have been 5 or 6 years ago that I just sort of like what I did with robotics, started just doing it basically.
And they got in terms of MRI, you were doing them before, but you were still doing the cognitive biopsy, and then you were started transrectal, but then just you switched to start doing cognitive transperineal.
Yeah. So basically, the transition was maybe 10 years ago. We got our first MRI, maybe 15 years ago. We got our first multiparametric MRI, a 3 Tesla. So we started to do cognitive fusion through biopsies transrectally. So at that point, I was doing a rectal swab, neomycin enema, Levaquin, unless it were resistant. I would do either Bactrim or Augmentin. I noticed because of probably the high prevalence of obesity here, we have a lot of patients with large prostates, and it was very difficult to target these anterior tumors. First, it was a long shot from the rectum. Secondly, there was so much calcification. Some of them, if they were small, if they were RADS4, they were hard to see. So that's when I decided, listen, I really have to rethink this. And that's when I got the UroNav. I looked at the Artemis, I looked at UroNav, I looked at the Coelis, and they all look great. At that point, BK didn't have a machine, and micro ultrasound did not exist, or was not available. All my friends at Fox Chase, at Northwell, at Michigan, they were using UroNav, so I decided to go with that. So I started doing transrectal true fusion. I liked it because obviously now you can see the target. An ultrasound, we did a study seeing what percentage of the time can you see the nodule. And it's 50% of the time you cannot see the nodule if it's a small RADS3 or if it's a RADS4. Most of RADS5 you can see, right? You can see them, but so half the time you may not need software fusion, but in the other half you do. The other thing that I liked about co-registration with something like UroNav is that if you have a lesion, an area of atypia or multifocal high-grade pin, and you're going to go in and rebiopsy, you have that data and you know exactly where you need to go, maybe to saturate that area if you're going to rebiopsy the patient. So I really like UroNav, and I just had to change the probe, the biplanar probe, to be able to switch to Transperineal. It was a pretty easy switch.
In terms of the imaging, the rendering or the mapping of those lesions, are you relying on a radiologist? You're doing it yourself?
Yeah, that's a great question, because that's a very important component, that if you're going to be moving into fusion, you need to sort that out before. In my case, I had to make the investment because it was by myself, but I do my own maps. There's a program called DynaCAD. It's what many radiologists use, and you basically you upload the DICOM images on DynaCAD, and then you have your axial T2 is the most important. And then your ADC map, your high B image, like your B2000 is your inverse of the ADC map. And then you have all your images together, and then you can basically mark the tumor in 3 planes, axial, coronal, sagittal, so you can create a 3D rendering of the prostate with the nodule. And I like doing it. Sometimes, I may see some nodules that maybe worry me that were in red, but most of the time it's pretty consistent. The radiologists, many of them have AI software that helps them with the mapping, which is great. I saw the new one by Philips at the AUA now, and it looked really nice, where it basically helps you do the sort of the first step after you do the volume analysis. Yeah, so it takes a little time, but I have to say I kind of like it, that at the end of my clinic, everyone's gone, I'm by myself, and I do my maps, and I didn't think I was going to like it that so much. The other thing is doing the maps myself. If the patient eventually needs a prostatectomy, I take I have a 3D video rendering of the tumor of the prostate and the tumor that I can take to the OR, and it helps me in the operating room. So I really like that too, because it's not only do you have the pictures, but you could actually move it on the Dynacad and play with it. It's like having a 3D model, right? I wish and people do 3D printed models, but this is good enough for me, so I like it.
So I was going to ask you, in terms of how did you become proficient in reading MRIs? Did you took a course? But I guess now the easy way will be you just wait for the AI and just
Yeah, that we don't have that yet, but we were lucky at Penn. We had wonderful radiologists. Her name is Parvati Ramchandani. Parvati Ramchandani, one of the pioneers with Howard Pollack in uroradiology. So every Wednesday we had radiology class with her in the morning, and she really, I mean, at the time we weren't doing diffusion analysis, obviously, but we got a pretty good idea of how to read MRIs during residency. So that was actually fun to do for both kidney and prostate.
So you mentioned before that the infectious rate was not the reason of switching to Transperineal. So and you mentioned some aspect, just the anterior plane, all that. What's the, I mean, other than that, I mean, what's the real difference between Transperineal and Transrectal in terms of, I guess, patient satisfaction, going back to usual, back to their norm, also in terms of cancer detection. So can you go over those?
Sure. Yeah. So I think I have to preface by saying that I have always used light sedation for all my prostate biopsies, and I know that's a super controversial area because most urologists don't. They do them in the office, in the local, and that's fine. But when I was in residency, we had one attending who did them under light sedation and the others awake. And I really liked light sedation. Like, I thought if I ever do a biopsy on a family member, or I need to have it done myself, I want to have it done that way. Because although the patients say that they tolerate it, their PTSD is real. I mean, when you have to rebiopsy them, they resist. So that's sort of where the truth comes out, right? And I think the golden rule is you should do for all patients what you would do for your family, right? So I'm very lucky that in our building we have a surgery center that's run by 2 anesthesiologists who are extremely efficient. And the turnover time is basically the time that it takes to clean the equipment and clean the room, and it's super fast. So I'm spoiled. I understand that other places it may not be that way. So you can, I mean, I do four biopsies and I'm done by 9:30, and then I can do clinic. So to answer your question, the prevalence of hemorrhoids here, because I don't know if it's because of obesity or diet, I mean, patients are really sore. I mean, I haven't quantified it, but patients do have rectal bleeding. I've never had to transfuse anyone or have problems, but occasionally the large Foley balloon in the rectum or packing, occasionally. And patients are sore with their first bowel movement. I think some of these studies that are comparing transperineal to transrectal have not completely qualified or quantified the issue of hemorrhoids. The second reason is just the idea of putting a needle with rectal coliform bacteria in the prostate. Just after a time, it just gives me chills. Like to me, it just doesn't make any sense. If you can do it with 2 sticks, so you just do one for the right lobe, one for the left lobe, and it just seems much more hygienic. Third, the issue of the microbiome. Like if you can do it with antibiotics, I admit, because it's an area that's very dirty, obviously you clean with betadine, but I give them 1 dose of Ansef. So maybe that's cheating, but I've never had an infection or 1,000 biopsies. I do give patients probiotics and yogurt the week after that dose of antibiotics to try to get their flora sort of back to their wild type. It's very nice not to have to do a rectal swab. The pre-op is much quicker in the office. I love saying patients to the family, Everything went great. I already gave him a dose of antibiotics. He doesn't need more antibiotics. And I just don't worry about infections. I've never had one, knock on wood. If you look at some randomized trials of the few that have been published, if you go no antibiotics on transperineal, the infection rate is not going to be zero. Okay, so you could have infections even with antibiotics, but I like giving one dose of Ansef. A lot of people go antibiotic free, and that's fine. I've done it, but if they're allergic, I give them a shot of Gent.
Enrique, are you doing a rectal enema just for better for the ultrasound probe?
Yeah, that's a good question because some people don't use enemas. I started doing that, and it really slows down my day if I start doing the ultrasound and I just can't see, and I have to put a betadine enema or an enema that right there on the OR, and the patient's asleep. And so I found that, sure, it'd be great. Patients hate enemas, I know that, but now they all get an MRI and they're used to like administering the enema, and I still use an enema. And the other question is whether, if you're doing it with sedation, whether you use local or not. There was a nice paper out of Sloan Kettering at the AUA. It wasn't a randomized trial, but it just compared different attendings, and they used some pain scale scores, and the study suggested that if you don't use Marcaine or Xylocaine, the patient will have higher pain scores in recovery room, which you kind of would expect. But I stopped using local when there was a Xylocaine shortage after hurricane here and then COVID. So I really haven't missed it, to be honest with you. Patients, I don't have data, right? I don't have questionnaires, but patients do fine. They wake up in recovery room after like they would for a colonoscopy and a snare. They don't complain. So I think you can go either way, whether you use local or not, but it goes a little faster. The other question people ask me is whether I use an angiocath or a metal needle. When I started Transperineal, I was using the Precision Point, which is a great device that basically holds the needle for you, and you can raise it and lower it. And in the beginning, as you're going through your learning curve, I think it's worthwhile using it, but our reimbursement here is so low that I was spending a big chunk of the fee on just the device. So then I start ordering just the metal needle without the plastic device, because I felt that freehand, I had a lot more control to be able to reach the nodule. And then when I got really good at it, I just started using a really cheap 14 gauge angiocath, and that's what I use now. You have to be careful, because when you're starting out, you can go through the angiocath, right? So you have to feel comfortable that you're not cranking the angiocath out of the way. That happened to me, but you could potentially shear the endo and leave it inside the patient. But the safest thing is to start with a needle, and then when you feel comfortable, you can do an angiocath safely. I think I don't think there's a problem.
Yeah, I have used the Precision Point for rectal spacing, and it works very good. And I'm putting the fiducial markers. So with COVID, I switched to doing them in the office because I couldn't. So I started doing them in the OR for just protection for ourselves. And patients were they never complained. No, I didn't feel anything. Everything was good. So like you mentioned, I don't use local anesthesia. Unfortunately, I'm still doing it transrectal, because the limiting factor will be anesthesia. They want to put LMA on everybody. I'm trying to convince them, hey, it's safe. Maybe if the patient is obese, then maybe put the LMA. But let's try to do it under sedation, light sedation. So hopefully in the near future, I'll start changing to transperineal.
Yeah, I think one of the issues with transperineal that I think we need to be objective about is that they do squirm and they move around. It is, if you do, I've done them in the beginning, I was doing them full local without anesthesia, and then you do your sweep, you have your prostate co-register with the MRI, and the patient just jumps off the table, and then you have to start over again, right? So when they're asleep, or it just goes so much quicker. So the transperineal needs more analgesia. There's no question. If you're doing true fusion, then you have to be careful so they match, because the patient starts moving around and you're gonna be off, especially if the nodule's small.
In patients that have PSA continues to go up, MRI negative or Pirates 2 on MRI, young guy that you say, hey, let's do a biopsy. What do you do, a 12 standard, or what are you doing with those patients if you do just a random biopsy?
Yeah, that's a good question. And these are such simple questions, but the truth is everyone does it a little differently. So first of all, what do I do with a normal MRI, right? So if the patient has a normal MRI, if they have a PSA density above 0.10, which normally high for me is 0.15, but to be conservative, they have a PSA density above 0.10, I will do a biopsy. If it's a PSA density below 0.1, so it's a 100-gram prostate with a PSA 4 something, I would do a biomarker. Okay, I think PSA density is one of the best biomarkers. It's cheap. It's really powerful. The second order I would use is a free PSA. Free PSA is below 10%. I think to me that means a lot. It's very inexpensive. It's like a poor person's 4K score. So I've heard people call it a 2K score. I think it's kind of funny. So you're saving a lot of money, right? But if you want to go more sophisticated, I've used 4K score. I've used PHI, Select MDX, XODX. But right now I'm sticking with my prostate score 2.0 from Michigan, from Lynx. I really like it because it has many genes. It's a urine test that doesn't need a rectal exam. It gets shipped to the patient's home, and they do the urine test without a rectal. So the patient ships it via FedEx, and it gives you a percentage risk of grade group 2 or higher, which is really what you want in older patients. If it's a younger patient, I don't get a biomarker. I just go ahead and biopsy them usually. If it's a 45-year-old guy, with a normal MRI and their PSA is 3, I'm probably going to biopsy them anyway. But if it's a 69-year-old gentleman, I really like biomarkers like 4K score or my prostate score to look at that. So if I'm going to do a biopsy, answering your question, I do a 12-core. I use the Michigan Music template. It's like a modification of the Barzell Transperineal template. If you divide the prostate up in sides, you do 6 and 6. I would also add, I would do 14 because I would do a right and left transition zone. So I would do a 14 core. If they have a negative MRI, but I'm worried about their PSA density.
And for bigger prostate, will you go 2 in each section, or?
Yeah, I don't. Another thing about transperineal, your retention rate is going to be higher. Okay. Yeah. So your retention rate is not like 3 times what it is transrectal, but it will be a little higher in those 100-gram prostates. So if they have a normal MRI, I'm not for like oversaturating the prostate. What you do when you do that, you just find grade group 1, which is what you don't want. I usually do 4 cores of the target if they have a nodule, and 12 of the peripheral zone. Yeah, that they have more than 1 nodule. Let's say they have 2 nodules. I usually do 3 and 3, because then you're doing, your retention rate really goes up exponentially. But even there, I don't think we looked at our retention rate. It's not higher than 2%.
Okay.
But for transrectal, it was less than 1%. So it's almost 2 to 3 times, I think.
And in those patients, I mean, a patient that has 0 urinary symptoms, even if he has a big prostate but no urinary symptoms, still the same, or is usually with these patients that already have some BPH that you're trying to make sure that it's not cancer and then schedule for something else?
Yeah, that's a great question. And there's so many of your questions could be little randomized trials, because what I've been doing now is I do an ultrasound PVR in the office. So let's say I'm going to do I'm going to do a biopsy of someone who has a 200-gram prostate and they say they void fine, usually I'll do a uroflow and a PVR. You'll be surprised. A lot of these guys walk around with 200 in the bladder. So those patients I will put on Flomax before their transperineal biopsy, even though they're saying that they void fine. So I put them on Flomax before, and then I keep them on it for like a week after the biopsy. It's just sort of made up, but that'll be a nice trial for patients who are at higher risk for retention.
I do a AUA symptom score on everybody more than 45 and PVRs. And like you mentioned, I mean, even if a patient is coming for ED, you do a PVR, it's 200, the symptom score is 20, and they think it's normal. Oh, that's normal because of my age. I mean, so good point there.
You asked me in the beginning how my philosophy regarding PSA detection has changed, and I guess I would go back to saying when I started out 20 years ago, I did not have the appreciation for the importance of PSA density, testosterone, BMI, family history, and race. I would say those are probably the most important ones. So how do I screen patients? I like the NCCN guidelines. So you get a PSA. In Puerto Rico, our mortality is higher because probably our racial admixture. So I would get a PSA at 45 if they have family history at 40. And if their PSA is 1, they can skip 5 years. If their PSA is higher than 1, then they can go annual or biannual, depending on their family history. But I think we are taught as urologists to correct for finasteride and dutasteride and double the PSA, but we're not really taught to look at testosterone. And our population here, 67% of the population is obese. So you'd be surprised. I never get check a PSA without a testosterone because I get a PSA of 2 with a testosterone 150. That patient needs a biopsy, in my book. I mean, if you replace testosterone on that patient and you get him eugonadal, his PSA is going to be over 3, right? So we need to do a better job of doing studies to really try to understand, like, how much should we adjust the PSA to if our testosterone is low, and maybe have an equation that we can all use. But we do it very quickly for finasteride, but for hypogonadism, but I just use sort of like a gestalt. So I tell primary docs, if your patient has a PSA of 2, I'm not going to do a biopsy, probably, but I want to see him. I'll do a rectal exam. I don't think the rectal is necessary for screening, but I think it's important once your PSA gets to 2, because if you have a tiny little bean of a prostate, your PSA density is high and you need a biopsy. If your testosterone is low, if you have your 2 brothers had prostate cancer, your PSA is 2. If you're Black, if you're Puerto Rican, then it's 3. You have to really individualize. So it's not one rule for everyone. If we come to terms with the fact that there is no urology workforce power to do screening, I mean, there isn't. Screening needs to be done by PCPs. So PSA of 2, you go to urology clinic, you get a rectal, and then you triage that patient to annual PSAs, biomarker, MRI, PRN as you need it, and then you decide where to go.
I think I remember when I was in residency, it was a study about making sure that you repeat the PSA because of all the false positives. That you go to one lab, maybe it's 4.5, you repeat it, now it's 2.5. So, I mean, you definitely have changed at that time how we approach PSA and try to incorporate velocity, density, other stuff into decision making, not just 3.9 is good, 4 you're going to die. I mean, definitely we're not there anymore.
I think we need to be a little bit more patient-centered and individualistic about each patient. And instead of just pulling the trigger, I mean, obviously we're having all this conversation, but the first thing I do is to repeat the PSA on everyone. I mean, because 30% of the time it will be lower if you repeat it. And I get a vein bursting reaction when they give antibiotics to patients to lower the PSA. I mean, it just drives me crazy because there is no data. I mean, someone decided that, and it's done all over the country, not only in Puerto Rico, everywhere. But it gives you a false sense of security. Most of the time, I'm sure it goes down because it would have gone down anyway if you would have checked it, right? So obviously, if the patient has pyuria, if the patient just had a raging prostatitis and their PSA went up to 50, I mean, you have to just resist the temptation. Please don't order an MRI. That happens. I see that in a lot of doctors who are not urologists who get a prostatitis. They treat themselves for a month, and then 2 months later they repeat their PSA and it's still 10. Well, it was 50. And they get an MRI and their prostate is blowing up with areas of low diffusion. That's probably lymphocytes. It's all lymphocytes, not cancer. So they freak out. That's something that I wish there was a little bit more restraint ordering MRIs and those patients. What I tell those patients, listen, we're gonna keep checking your PSA every 2 months until it stops coming down. And it'll come down to 50, from 50 to 25 to 10 to 5 to 2. And it may take us 8 months for it to come down. But as long as it's coming down, we're not getting an MRI. It's going to be positive because you had a prostatitis. You just have to wait and improve your micturition, right? Make sure that they're on the appropriate therapy. But that's a pitfall. One of the other side of the coin of MRIs, obviously.
Rica, you mentioned some of the early indications to do biopsy. When I was in residency, another change was the task force. And now we're seeing some older patients that might have improved with early screening, not getting that early screening and presenting to the office with metastatic disease. And I see it all the time in the hospital. Are you seeing that prevalence now, more metastatic disease than for example, 10 years ago?
Yes. In Puerto Rico, luckily, the screening didn't really go down as much because there has been always this conscience about the fact that our mortality is intermediate between Hispanics in the mainland and Black patients. So our mortality, if you look at our Puerto Rican cancer registry in the last 5 years, mortality has gone down 3% every year, as opposed to the mainland, which has gone up. So, however, although mortality on the registry has gone down, the type of cancer that we're seeing is more aggressive, no doubt. I called my pathologist today, our pathologist. I said, listen, I have a database of all my prostatectomy patients. And I said, listen, I was just looking at the cases in the last quarter, and of the 50 prostatectomies I did, 80% had T3 disease. I mean, this is crazy. I mean, this isn't something new for me. And the PSA necessarily has the PSA is always between 4 and 6. I'm like, are you seeing this with other surgeons as well? And he's saying, yes. I'm seeing about a 5 to 10% increase in positive nodes in the last couple of years. And
these are MRI patients that were just confined to T2 or T1.
Yeah, no, a lot. I do operate on T3s if they're young, and they have in those patients, I do get a PSMA. I usually try to recommend for them to go on a trial. Brian Chapin has a couple of nice trials that are of neoadjuvant therapy right now. I try to get them to go to a trial, but financially, it's not really possible for most patients. So if you have a patient with a PSA of 15 and a T3A exam, but everything looks good on the MRI and on the PET, they understand it's going to be a wide resection on that side, and they'll need an extended node dissection. Then I do offer them surgery. I wish it was in the context of a clinical trial, but that's what we have here. I don't know the answer to why we're seeing with this increased aggressiveness, because if you look at the cancer registry data in Puerto Rico, screening has really continued in Puerto Rico. So I don't understand, above my pay grade. It's probably diet. The diet here is not Mediterranean at all. It's the anti-Mediterranean diet. The type of cancer that we're seeing is really completely different than before.
What are we talking about? Doing earlier prostatectomy versus waiting?
Nah, I don't do prostatectomies on patients with grade group 1 unless it's a 37-year-old with 5 positive cores of grade group 1, which, I saw one today. And a RADS5 nodule, I won't do a biopsy on that patient. I just take them straight to the OR, and they always wind up having grade group 2 or more. But on my database, I looked at the data 2 weeks ago for a talk I was putting together. Only 6% of my patients are grade group 1. Okay, so I have 450 patients on my database on active surveillance. If their PSA density goes up, if they develop a RADS5 nodule, I move very quickly, but I'm far from recommending someone a prophylactic prostatectomy just because they have grade group 1. I think the solution for us in Puerto Rico, because we have such limited workforce, is to have everyone who has a PSA of 2, without a rectal exam, everyone who has a PSA of 2 to see a urologist. And if they have a very low testosterone, get an MRI or get a biomarker. And those patients get really held by the urologist for maybe yearly or every 6 months follow-up to try to catch them before their PSA goes above 3, because then it's too late. They're too young. Regarding your question of more elderly patients, I like the Charlson Morbidity Index, which is the calculator. And I wish more PCPs would use it, because if you input the data on a 70-year-old who has heart failure, the chance of them being alive at 10 years is 15%. So why are they ordering a PSA on that patient? But there's no nuance, right? It's problematic. I see patients all the time, with defibrillators, and I try to understand. I'm like, so you have a defibrillator, so you either have sudden death or you have an ejection fraction of like 30. You remember the number? And they're like, maybe 25. I'm like, oof. So it's like, okay. So those patients don't need screening, right? Even if they're 65, right? If someone is 73 but runs a couple 10Ks a year and they have no medical issues, then they can maybe safely continue screening, and that's fine. But if someone has a less than 50% chance of living 10 years, which is what the Charlson Morbidity Index will tell you, do not recommend them getting a PSA, because you go down the rabbit hole of the PSA, the MRI, the biopsy, and what do you do? Right? So I have no qualms in telling them, listen, just let's not check a PSA anymore. Let's just forget about it. You're going to be fine. And because if someone has had a CVA, or they have severe claudication or severe heart failure, really, unfortunately, urologists are not the ones making the decision regarding getting PSAs on those patients. So
Yeah, I do see them. Sometimes I say, I'm not going to do a biopsy on them, but sometimes they feel like if I say that, go back to your primary, I don't want to see them. So sometimes I feel guilty, and okay, I'll see you in a year with a PSA. But knowing that I'm not going to do anything about it, regardless of the number, because like you mentioned, but sometimes it's easier just to put the order for the PSA rather than really have the conversation, which is what I should be doing, instead of just, hey, don't worry, yeah, we'll do it next year.
yeah, and I think that's where biomarkers are really helpful. I mean, I started using the 4K score, well, maybe 12, 13 years ago, and because of the cost, I really slowed down and tried to move to other ones, to try different ones. But it's great to be able to tell someone, listen, your risk of having a clinically significant cancer is so low, let's just stop. Oh, there's one more thing. You asked me about why I moved to Transperineal, and I forgot to tell you really one of the main reasons. And it's the fact that I think that focal ablation is something that's going to be meaningful in the future. And the gateway to focal ablation is the perineum. So if you get good at biopsying, then you get good, then you can move on to that next echelon, next level, which is whether you use cryo or IRE or, HIFU, but, obviously transperineal approaches would be laser, IRE, focal, cryo. So you'll be amazed on how good you get when you start doing the transperineal. I think eventually we're gonna PSMA PET MRI is gonna become mainstream because it's what we need to do. Forget CT, it'll be with MRI, and I think it's a matter of time whether we're gonna have artificial intelligence guided, image guided, robotic biopsy systems that you basically set up. You do the MRI with the patient, maybe in a frog leg or even lithotomy, and the MRI will be able to, you'll have a system where the device will biopsy the nodule perfectly, just like the Mako system that the orthopedic surgeons use for their hips and lining up the angle and everything. I think that's that's the future. And then if you add, as these isotopes eventually become cheaper, where you can maybe use a SUV max or other yet to be determined characteristic that will tell you that will correlate with the tumor aggressiveness depending on that level, and maybe help you decide whether you need to pull the trigger and do a biopsy or just to leave it alone. So that's definitely something that it's kind of Star Trek-y, but it has to come. I mean, I think we're moving forward. So being able to dominate the perineum and do everything through there and leaving the rectum, I think has a lot of gain for patients.
Yeah, I mean, I have heard before, the comparison to the heart, that before everybody was getting CABG, and now there's doing stenting, and CABG will be to the patient that cannot, either there's not enough space to put stents. So maybe for prostate, from what I hear, I mean, it will be more or less the same. I mean, you try focal first, maybe, and if it fails, then you will go, we do the prostatectomy.
I went to inside the room at PET, actually, where they do the ablations for the cardiac ablations, and talk about Star Trek. I mean, it's amazing. It's not a 40-inch screen. It's an 80-inch screen with all the voltages and the images and the MRI that they had for the patient before, the heart, and everything superimposed. And then they add the angio when they do the cath to see where the lesion is in relation to LAD, and they're able to ablate it, avoiding the LAD, and it's pretty amazing. So I think we need to really target that same, that should be our goal. I mean, I think it's a pretty exciting area for focal. I mean, this is my first AUA where I really thought, man, focal is really here. I mean, and obviously I think it's for grade group 2, right? I don't think, as an oncologist, I'm not crazy about applying it to patients who are either on active surveillance or who have, a high volume of primary grade 4, right? So, but I think there's plenty of patients that are candidates. So
yeah, sometimes you do the MRI, only one core comes back positive. Like you mentioned, maybe a group 2, group 3. Sometimes, even if it's young, sometimes, hey, we're going to have a prostatectomy, but that's where we're at now. So maybe in those cases, you can offer something different. So Ricard, so I think, I mean, we have covered a lot today. The lastly, let's mention, I know in Twitter, I know you're using WellPrept. How has that improved what you're doing in your office? I mean, I use it, definitely. We send messages to and I have your videos. I show the patient, especially the Spanish-speaking patients, to listen to your explanation of the biopsy and all that. So definitely, what has changed in your practice?
yeah, I'm glad you brought it up. And first of all, kudos to David Keynes and his team. I mean, they make it so easy for someone to walk into the WellPrept system and be able to just turnkey, basically. Without hyperbole, I think it's the single most important change I have made in my practice in the last 10 years, having WellPrept. And I think in terms of wellness for me, I think in terms of patient satisfaction, reducing risk, medical legal risk, I think it's important as well. And how I use it, basically, my practice is very simple because all I do is fusion biopsy, robotic prostatectomy, and now focal in some patients, right? So I have very few videos, but when patients call my office for an appointment for a newly diagnosed prostate cancer, my staff sends them a QR code, or they go in and they're able to go to the area that they're supposed to and see a video of me sitting right here, sort of explaining either in English or in Spanish, A to Z, like everything, that, my philosophy regarding low risk prostate cancer, intermediate risk, high risk. And then it explains, there's another video of prostatectomy explaining the risk of the prostatectomy. There's a tour of the operating room showing them the robot and all that. Maybe some of them are a little long, but it's nice to have that depository, that's evidence there that the patient, your note says that the patient was directed to that site. And then when they come in, what's amazing is when the patient comes in to see you, you start giving the spiel like you're used to, you've done for 20 years, and they stop you. I mean, that's when you really realize. They stop you and say, "Oh, doc, we saw the video, blah, blah, blah. And I just have a question about this or that, or I have a friend who this," and if the conversation becomes about answering questions and not just you talking. The other thing is it saves you tremendous amount of time. I would say an hour a day, most, maybe 2 hours on pre-ops, because a patient comes in for a prostate biopsy and our nurse asks them, "You saw the video?" Yes. They come in, they see me. "Do you have any questions? Did you see the video?" "Yeah, that was great. When can I start my eloquence after?" Or whatever, something that you surely didn't address on the video. But then, "Okay, any questions?" "No." Sign here, and they go. And it turns a pre-op visit from a 15-minute visit to literally minutes. And then when they leave the hospital after a prostatectomy, they get the QR code for Kegel exercises, for the vacuum device, how to take the pills. There's another video explaining why we need to check PSA, because they ask you 100 times, if I don't have a prostate, why do I need a PSA? And then you can explain, why that is, and what is a normal PSA level after surgery, blah, blah. So all those spiels that you're giving 1,000 times, it's great when you see them sharing them with their family members, or you get a patient referred because they saw your videos that were shown by the patient. So I think it's just good medicine. It's nice to get home an hour earlier, but it's nicer just to have happy patients, right? So the impact of WellPrept and my staff's wellness and my wellness is really measurable, I have to say.
Not like you mentioned. I mean, even when you that first time that you talk to the patient about the results of the biopsy, that they're positive. You mentioned the C word. I mean, you told me not to mention the C word. Use something different to don't say cancer, because they're gonna stop listening to whatever you say afterwards. But definitely seeing a video after about explaining what type of tumors they have, or possible tumors, ones that are less aggressive, more aggressive, that really helps.
Yeah, so if anyone, hasn't looked at WellPrept, it's super simple. All you do is you get your laptop open and you record a short video, and you just create a YouTube channel and just put the link, you literally copy paste your link of that video to your page, and then the WellPrept community shares videos. So you can use, if you have a video from someone in a different language that you want to use, that you know is a person who is very reliable, then you can use that video, and we all share them amongst each other for the group. So I would definitely look into it if you haven't.
So Riga, we touched multiple topics. So PSA, get the density, watch the density, free PSA, if less than 10, definitely indications for biopsy. Markers, very important. And I'm going to start adding markers to the patients that I don't want to see anymore, or we shouldn't do the PSA. I say, "Hey, don't worry, you're good." Just so that the patient doesn't feel that I'm not doing anything else. Transperineal, MRI fusion guided biopsy sounds like it's the way to go. Less chances of infection. I mean, in your case, that wasn't the issue, but definitely a lot of things moving in that direction. Like you mentioned, already some places going 100%. Transperineal, focal in the future. Anything else you want to add?
No, I think we pretty much covered everything. I think the key is just to individualize, to, take each patient, and I acknowledge that I wasn't doing that good of a job at assessing mortality on my patients, as I decide whether they're going to continue screening or not. And now I am being much more aggressive about, listen, if you're going to get a PSA, then you need to go on the Mediterranean diet. You need to start exercising. If you haven't had a stress test in your life, which many haven't, and you've been diabetic for 20 years, and you need to minimum get a treadmill test before you even consider like going down the rabbit hole of PSA, MRI, biopsy, because there's no point. I mean, all these competing risks of mortality are many times ignored, and me included, right? So I'm trying to be even more careful with my health. As you say, I need to lose more weight, I need to exercise more. With WellPrept, I have been able to point patients in the right direction a little bit better with regards to what is the anti-inflammatory diet. I mean, it turns out I was talking to a friend of mine who's a rheumatologist, like the anti-inflammatory diet for RA, it's exactly the same Mediterranean diet for prostate cancer. I mean, it's an anti-inflammatory diet. It's an anti-cancer diet, right? So you tell a patient and you teach them where to go so they can learn how to reduce their risk of arthritis, hyperglycemia, overall risk of cancer, etc. I think it really empowers the patients. And you tell them, listen, I'm going to see you in 6 months. I want you to lose 5 pounds between now and 6 months. And we're going to be doing 5 pounds every 6 months. This is not going to be a race, just going to be slow. And I think that really makes an impact.
Excellent. Well, Rico, a pleasure having you here. Thanks for giving us your knowledge and part of your time.
Well, listen, thank you for the opportunity, and I have to dust off my tennis racket now that you're playing again.
Yeah,
if you guys don't know, Ocho was an MIT star in tennis, so someday we'll meet on the court, hopefully.
Let's see. I'm playing pickleball and paddle also, so just trying to keep healthy.
Nice. All right, well, thank you very much, Arche.
Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.